Now they can actually hear us on TV. Please note that some members will join us as their schedule permits due to other hearings this morning, and we assume people will be coming in and out, and we'll take member testimony as they would like. I'd like to start by thanking the members that have joined us today, specifically Nora Campos. We're here to talk about something that isn't always comfortable for folks. It's the value of breasts and how women's bodies are treated within California's worker compensation system. This may be an unusual topic for a hearing, but last year was a call to action for such an informational hearing. When we presented a bill to the governor, AB 305, that basically said women can't be discriminated against in workers' compensation, his veto message stated that the bill misunderstood the American Medical Association's evidence-based standard in the impairment guide used in workers' compensation disability decisions. On the contrary, AB 305, and I believe the AMA guide, misunderstands and undervalues women. Last year, I met female workers who have gone through the ordeal of being diagnosed with breast cancer due to their jobs, had invasive surgeries, complication, and years of impact from a disease that can reoccur at any time. After all of this, they were told by the workers' compensation system that permanent injuries due to their breast from cancer treatment are worth little or, in most cases, nothing. The veto message from the governor said that no group should receive less in benefits because of an immutable characteristic, and the workers' compensation system must be free of gender bias. These last two statements are things that we can all agree upon. So today we begin the process to ensure there is public inquiry into the evidence of the value of a woman's breasts. Starting with this hearing by way of the Select Committee and the Women's Caucus, the legislature is beginning to gather a record to show the evidence-based medical and psychological value of women's breasts. The goal of eliminating gender bias in the workplace, which includes workers' compensation, can and must be accomplished. It's clear that the legislature will not sit idly by while women are being treated unfairly by our state's own rules. With today's hearing and the ongoing information gathering, we can still address this problem. I'm excited that we had some people join us, Melissa Melendez, to show this is truly a bipartisan, a member of our Select Committee on Women in the Workplace, as well as the Chair and Vice Chair of the Women's Caucus, Hannah Beth Jackson and Christina Garcia. If we'd go ahead and allow people as they'd like to speak before we bring up the speakers.
Very briefly, I want to thank the Chair for bringing this issue forward. It is an important issue to make sure that we are eradicating and ridding ourselves of the kind of gender biases throughout the state, throughout our mindset, throughout the kinds of discussions that we have going forward, particularly with respect to women in the workplace. We are therefore proud to lend our support to you. And I heard this bill when it came before the Labor Committee in the Senate and supported it, and was also disappointed that the measure was not signed, and I appreciate the opportunity to provide further information and elucidation to those who are skeptical of the importance of this issue. And we know that the purpose of the workers' compensation system is to make a person whole after a workplace-based illness or injury, and it is crucial that that system of workers' compensation is effective and gender bias-free. So we have come a long way. The Women's Caucus working on things from equal pay to sick leave. We've overcome many barriers in the workplace already, but this is one that I think is critical to discuss as well. And I think back in my own mother's generation, it was legal to have female employees sign contracts that would terminate their employment upon marriage. That was legal. It was also legal to require female employees to be sterilized in order to get certain jobs. This kind of thing, as shocking as it may be, did exist, and we've worked hard to eliminate those biases, and now it's important to work to assure that workers injured in the workplace are treated with a system that is free from that bias. So with that, and the fact this issue fits within the framework of dealing and focusing on economic security for all women, which our Women's Caucus is committed to this year, I would like to thank you and look forward to participating, at least to some extent. That I have to leave, and I apologize, but I will be very interested to hear how this turns out.
Thank you. I am, like most women, multitasking today, and I am required to be at 3 hearings at the same time, so I'm not going to be here. But I wanted to come by and, first of all, thank the Chairwoman Gonzalez of the Cell Committee for continuing with this fight, and everyone else that's here to learn. It's a little insulting that we have to prove our worth, but I think it speaks to the value of having women legislators that we don't back down, and we will do the hard work to get our point across. The inequities we see are many, and we've overcome a lot of barriers. A lot of us have been fighting for a long time, but we have a long way to go, and we have a long way of educating our governor of certain items that are out there. And so just wanted to come by and lend my support and thank everyone for continuing the fight this year. Excited to work with everyone on this. We have challenges of balancing work, family. We have challenges of balancing childcare access. We have challenges of getting pay equity. We have challenges of our tax code being discriminatory against us, and this is just one of many other challenges that are out there. So while I expect success at some point on this issue, I know we're not going to back down. We have many more challenges to overcome together on that. So I'm grateful for my colleagues and everyone here that's working on this issue. Thank you.
Thank you, Madam Chairwoman. I just have a few brief comments today. I'm delighted to be here, and thank you for inviting me and putting this together. And I am very pleased that this is a bipartisan effort. I am forever the optimist, though, when it comes to women's issues. I am grateful that we don't live in the times, that I didn't grow up in the times that Senator Jackson brought to light. And we have come a long way. We don't live in those times anymore, so hooray for that, right? We don't need to live in those times anymore. But I do know that when it comes to women's issues, and particularly women's health, if women aren't the ones who are beating the drum and screaming from the rooftops, oftentimes nothing is going to happen. We have to be our own advocates. And so it's nice to see so many women here, and gentlemen too, in the room here, although some of you I know have to be here. But we, our husbands, our fathers, brothers, sons, they have to advocate along with us. But when it comes to women's issues, this is how it gets done, ladies. And thank you for inviting me and for having this hearing.
First of all, I want to thank Ms. Gonzalez for her continued efforts on making sure that women's issues are at the forefront. I try to look at the positive thing. So the governor vetoed this and gave a very strong message. So now it is, the reality is that he may have done us a favor indirectly, because we are now organizing to scream from the top of our lungs that this is a priority and that we are not going to stop till he signs this into law for women across the state of California. And I say that because I was in a similar situation like Ms. Gonzalez, where a woman's issue was had a message as well. And you know what it does for us as women leaders, and with your support behind us, it makes us much stronger to say that our voices are at the table. We're not behind anymore, we're at the table. So issues pertaining to women's health, women's pay equity, and other issues that affect the advancement of women is going to be at the forefront this year. We see it on a national level. And so that's a good thing for us as women, because now we have the spotlight to talk about the issues that are important to us. And we're having a conversation about women's breasts. So we've got to find the good in that conversation, because what it means is that our bodies are valuable. And we need to talk about this type of things in this type of setting. So I'm so excited about this, looking forward to the conversation, and want to once again recognize Assemblymember Gonzalez's leadership on women's issues.
Thank you, and I do want to thank the governor for his veto. I think I was shell-shocked. I happen to, have lost a mother to breast cancer, and she lived with 17 years with one breast because of a mastectomy. And so to me, it became common sense that obviously the loss of a breast has tremendous value, both psychological, emotional, even physical in one's life. I took it as a no-brainer when we did this bill, and as it passed in a bipartisan fashion through both houses, that is an issue that was clear to folks. It clearly wasn't clear to the governor, and so I am thankful that we get to have this very evidence-based discussion about women's bodies, and in comparison, quite frankly, as we did in the bill, to men's bodies. It's amazing. We never had to have that discussion for men. They accept as scientific proof that prostates are worthwhile. So I think that we actually will establish a record that will help in the future with some other decisions as well. So I thank him for giving us this opportunity. And I am excited to bring up our first speaker, who's just going to give us a legal and medical overview of the California Workers' Compensation Guidelines, Julius Young. He's a workers' compensation attorney with Boxer and Gerson, and author, editor, lecturer, former settlement conference judge. So he's going to set the stage. All of our speakers have about 5 minutes. We have Laurel from my office is going to do the timekeeping there. We're going to try to keep people on time. I'm a little strict on this, just to warn you. Great. And then we'll open up to questions after each speaker. Thank you.
Thanks. It's great to be here. And please give me the hook if I go over time. What I want to do is give a little bit of overview about the AMA guides. Because you're going to have some speakers later talk about the specifics of how the breast is dealt with under the guides and litigating those kind of issues under the guides. Let's get real at first. We're talking about this book, the California law in 2004 under Schwarzenegger. They mandated the use of the AMA guides. This is the 5th edition. There were a number of other editions of the guides. They started out as being simply articles in the Journal of the American Medical Association back in 1958 to 1970. Then they published the first edition. This was the 3rd edition of the guides in 1988 and revised in 1990. And in a minute, I'm going to talk about some of the criticism of this from a gender standpoint. I want to contrast this with what they call the MTUS, which is the Medical Treatment Utilization Schedule, which this is what governs workers' treatment under workers' comp law. And this is really evidence-based because they adopted a guidelines from the ODG guidelines, the Official Disability Guidelines. It's a Work Loss Data Institute out of near San Diego. And this is evidence-based. This book, although they say it's based on evidence, it's largely based on consensus of the editors in different fields. Anyway, what is the AMA guides? Okay, it sets up a definition of impairment. It defines impairment as a loss of use, or derangement of any body part, organ system, or organ function. So the 5th edition has 18 chapters which deal with different body systems and different parts, including sections on skin, urinary and reproductive systems, mental and behavioral disorders, endocrine systems, and some of these chapters put an emphasis on so-called activities of daily living. So the guides set up a framework to establish a percentage of whole person impairment. Okay, so that's what we're going to be talking about today, is how these guides establish whole person impairment for breasts, for example. The guides claim that in evaluating impairment, they consider both anatomic and functional losses, but they admit that some chapters place a greater emphasis on either anatomic loss or functional loss, depending upon the specialty. They define anatomic loss as a damage to the organ system or body structure, while functional loss refers to a change in function. So there have been a lot of criticism of the AMA guides, and I have 2 more minutes, so I can't really go into all the criticism, but for gender issues, there was a very important article in 1990 in the Harvard Law Review by Ellen Smith Pryor, and I can give a copy to the committee for your record. This showed in the 3rd edition all kinds of problems with gender discrimination. I'll just quote from this. This is from the author of this article. Examples in chapter include a woman who led a normal life caring for 3 children in her home, a woman who remained able to do kitchen work, go shopping, a woman who remained able to care for her house, a woman able to do light housework, women who increased breathlessness while mopping or cleaning, and a woman able to perform household duties. By contrast, they used examples of men who were active participants in sports, unable to do tennis and hiking, unable to play golf. I mean, it was the contrast between the two, and at that time, there have been some changes, but for example, an impairment of the penis resulted in a 5 to 10% whole person impairment when sexual function is possible, but there are varying degrees of difficulty of erection, ejaculation, or sensation. On the other hand, for women, it was a 0% impairment where the vagina was adequate for childbirth and sexual intercourse was possible. So, a real difference in the way it was women and men were treated then. That was the third edition, and my time is pretty much up, but I think we're going to be talking today about the way the fifth edition deals with women. So, thanks very much for having me.
If you have a couple more minutes, I was actually fascinated. So if you'd like to continue for a few more minutes to get us to today, I'd be more than happy to give you.
Okay, well, we're going to actually, I think some of the later speakers are going to connect the dots to bring us to today. So I think we can.
I do have just one question. So in my understanding, the loss of a breast is 0 to 5%, depending of whether or not you're of breastfeeding age, basically, you can of child rearing age.
Right.
In which case, it would be up to 5%.
Right. There may be ways to get a higher rating under the Alvarez-Guzman case, which they can explain ways to use other chapters, tables, or methods but a lot of those require having a lawyer and litigate a case, which creates more frictional costs for women in terms of pursuing these things. So I think Crystal Schoenfelder is going to be a witness here in just a minute. She's going to talk more about the specifics of that.
So I just do have one question. So clearly they're assigning some sort of value to the functional loss of being able to breastfeed.
Right. There's the way this book is constructed, they're assigning basically what they call consensus-based WPI figures, whole person impairment, that there's concerns about the inconsistency between various chapters, for example. But is it really scientific? I mean, the governor's veto message said that the AMA Guides was an evidence-based system. I think there's some question about that. You can debate whether it's evidence-based or consensus-based based on experts. But at any rate, it seems that there has been a large and long history of gender-related issues in the AMA Guides.
And his veto message specifically said that he was concerned we are using an unscientific method, and I will grant him that. Just common sense is not scientific method. Nonetheless, would you suggest that the functions assigned to the breast in this AMA guide, specifically if there was no function assigned for loss of sexual abilities, I suppose, is that scientific based? Is it, even if it's consensus based?
How's that scientifically based?
So you don't see a scientific based value system that has produced this guide?
I think it's basically a bunch of doctors sitting around in a room and deciding what percentage of the whole person has been lost. And the question with women with some of these things is, are they really adequately addressing the effect of the loss of use in terms of the whole person?
And so you would say our decision in a workers' compensation law to utilize the AMA guide, which is not scientific-based, was a value-based decision. We decided it was a valuable resource by which to rely on. There's no consensus. There are other guides that provide a different percentage.
Right, there are other guides. There are other ways of evaluating disability. And again, the AMA, I mean, there's a 6th edition of the AMA Guides. I'm not sure exactly how that rates women's breasts, but there is a 6th edition. So this is all sort of a work in progress.
Thank you.
Just one question. So, as I understand it, the view is supposed to you look at the anatomical and the functional loss.
Right. The anatomical, right, and the loss of use or the loss of the guides are. It's a lot of this stuff is very fuzzy in terms of because they're talking about the importance of activities of daily living, but they're also talking about the loss of use.
Right, and from what it sounds like to me is you're suggesting that the determination is unscientific anyway, and that the effect of loss of use to the whole person, which is the criteria, or one of the criteria, is determined by a group of doctors sitting in a room making sort of subjective decisions that don't sound like, if golf and things of that sort are the criteria, that there are too many women in the room when the decision is being made. Is that a fair statement?
I think that's fair.
Okay, thank you.
Thanks.
Thank you. At this point, I'd like to bring up the panel on the value of a breast. We have Dr. Cass Brown-Capel, an oncology psychologist and breast cancer survivor, founder and program director for Save Ourselves. She should be coming up. We're going to have you all come up if possible. Do we have enough seats for everybody? Or at least be in that front row. For a medical perspective, we have Dr. Claudia DeYoung, a breast health specialist, surgery and oncology departments. And for a ratings comparison, we have Katrina Eagle. She deals with the Veterans Law. She's a Veterans Law attorney and deals with, of course, the Veterans Guide, which has differing forms. At least up there, if we can get another chair. We can get her another chair. We'll go ahead and start with Dr.
Capel. Good morning. I'm Dr. Capel. I run breast cancer groups for Save Ourselves Breast Cancer Organization. I've been doing this for 23 years, and I would like to say that today's the 29th anniversary of when I found out I had breast cancer when I was 32 years old. So I'm going to talk about what happens when a woman loses or has a breast amputated. Yes, it's not as, say, functional as, say, an arm, but when a woman has her breast amputated, it changes a lot of things. It changes the way her clothes fit. If a woman has a bilateral mastectomy, which a lot of women opt for because they're afraid of this coming back, when they raise their arms up over their head and they're wearing prostheses, guess what? The breasts stay up while when their arms come down. I just brought a exhibit because some women are said, well, here, use this. This will make you feel better. Well, let me tell you, this does not make people feel better, but this too is functional in that when a woman has a mastectomy and they go without a prosthesis, say at home, which many do because it's not real comfortable to be wearing this around, it weights the spine unevenly. Years later, 10 years later, they have the worst premature arthritis of the spine causing debilitating pain. When I talked about the way clothes fit, the shoulders, even with the best reconstruction or best prosthesis to even things up, the shoulders often don't fit. They have to be very careful about where, if there's anything even remotely that could show cleavage, it's not even. A lot of women are left with a concave breast. Women who have their breasts amputated have phantom pain and phantom sensations. Oftentimes that the loss of nipple sensation is big. It's very big. Women, years later, they go into a cold room. They still have the sensation of their nipple contracting, puckering up. Oh, oops, I just don't have a nipple. And they still have this like a tingling that goes on. Also, we're going to talk about the sexual aspect. For some women, nipples are extremely erotic for sexual stimulation. And when a woman loses or has a breast amputated, that's just gone. That's just a physical component of having a breast or two amputated. Plastic surgery, some people mistakenly say, oh, well, look, you got a new set of boobs out of this. And by the way, boobs is sort of like a four-letter word for breasts because they're breasts. It's a slang term that's not appropriate. Like someone who's a minority being called a slang term doesn't show respect. But that's another story. So what happens is... oops, I lost my thought there. I'll come back to it. Yes, plastic surgery, thank you, is not the answer to breast cancer. I've been doing breast cancer groups for 23 years. I've seen face-to-face over 2,000 women, and of those 2,000 women, say about 30% have reconstruction of some kind. And I can count on one hand, not two hands, the number of women that are completely happy with both the way their reconstructed breasts look and feel. Many feel like they're lying on orange peels when they're, or orange halves when they're on their stomach. Some people have such ongoing pain with their implant that they have to keep their seatbelt away from their chest. Women get infections like 3 years later and the body rejects the implant. I have a friend who's had 19 breast surgeries trying to get symmetry on the one side. When a person engages, usually a woman, but we have men too, engages in the breast reconstruction process, it's a long, arduous process, often fraught with multiple complications. Some women come out and they look like train wrecks. It's horrible. Some women, and it isn't necessarily the plastic surgeon's fault, because sometimes it's the women's bodies. Every woman responds differently to having a foreign body inside them, and some women's bodies form this capsular contraction. It's very painful, leads to a lot of scar tissue. That's just a physical component. I was told I have 6 minutes, so I'll try to be brief. We can talk about the effects of chemotherapy, what that does to a woman. I know we're talking about the value of a breast here, but we're really talking about breast cancer. And chemotherapy affects cognitive function. It greatly hampers a woman's ability or a person's ability to encode and retrieve new information. It makes word finding very difficult. It often changes the vaginal flora, changes their intestinal flora, so foods, even years later, they can't have. Some women's vaginal dryness is such that they bleed every time they have a bowel movement, or they need a child's speculum when they go in because the atrophy that happens. And people say, or when their hair comes back, it comes back differently, or it comes back with male pattern baldness. Breast cancer, unfortunately, is forever. And I could tell by your body posture, my time is near up. So I will.
And we're going to ask you to stay up there because once we get through the panel, then we'll open it up to questions.
And then I have a brief letter from Dr. Amy Wandel, plastic surgeon in town.
Wonderful. Thank you. And we'll put that into the record as well. Next, we have Dr. Claudia DeYoung.
Morning. Can you move this nice compared to, I don't know,
You want to sit on it?
Can everybody hear me? Yeah, okay. Good morning, ladies. So I'm Dr. Claudia DeYoung. I'm and gentlemen, sorry. I am a board-certified internist who did a women's health fellowship after my internal medicine training, and I have a particular focus in breast health. For the past 13 years, I have run a breast clinic at a local academic medical center, and for the past 2 years, I actually have been running a breast cancer survivorship program that deals with the physical and psychological sequelae or medical consequences of being diagnosed with breast cancer and being treated for breast cancer. I'm involved, like Cass, with a lot of support programs, and so the bottom line is I know breast health. I know breast health from the spectrum of benign breast issues all the way through cancer. And I know and understand the impact that this organ has on a woman's biopsycho and social well-being. So I'm here today to let you know that for women, their breasts are so much more than just a body part, and their sole purpose is not just to breastfeed. A woman's breasts are a part of her female identity, both physically and psychologically. In addition to the physical effects that breast cancer surgery and breast cancer treatment can have, like, Cass had mentioned the disfigurement, the asymmetry, the chronic pain, the lymphedema some women deal with for years, et cetera, the list goes on. Emotionally, breast cancer surgery is unlike any other type of surgery for a woman. Whether she has a lumpectomy, a mastectomy, bilateral mastectomies, reconstruction, the impact that breast cancer surgery has on a woman's self-esteem, her body image, her sexuality, huge. In fact, I think any health professional that deals with cancer survivorship would agree that breast cancer patients are among the most complex because of the various treatments that breast cancer patients undergo, including anti-hormonal medication, as well as the psychological burden that breast cancer often has on a woman. So for all of these reasons, I'm quite concerned that the current AMA guide that dictates disability ratings for breast cancer does not reflect the real-life impact that breast cancer surgery and breast cancer treatment can have on a woman. You know, as I was putting these thoughts together last night, two women came to mind just to kind of paint a little bit of a picture. And I'll name the first one as Margaret, who I saw last week. And Margaret had breast cancer surgery last year. And she had lymph nodes removed from her axilla, or armpit area, which is often the case during breast cancer surgery. And she is actually dealing with chronic swelling of the ipsilateral arm, or the same side arm. It's a condition called lymphedema, and there's no cure, and it's lifelong, and it is quite disabling for both men and women who have lymphedema. And then I thought of a patient I just saw the other day. I'll call her Susie. And Susie actually had a mastectomy 2 months ago. And Susie, to this day, has not looked at her chest wall in the mirror. Nor has she shown her husband. And I'd like to say that these situations with Susie and Margaret are rare, but they're not. I see these women day in and day out. And this is really the main reason why I'm here to advocate for these women. So, you know, the breast is just so much more than just a mammary gland whose sole purpose is to breastfeed. The breast as an organ defines us as women, and when this organ is changed, altered, removed, the physical and psychological impact that it has on women cannot be minimized. So those were my thoughts.